I want to share one thing with you. So on Monday, we did the information about everybody, where you're from, where you are now. So this is people's current locations. And you can click on people's names, and it has your information there, where you live, your organization, your meal, and all of that in this map. I'll send these links to Ashley and to Joe, and they can send them out to everybody so that you can see them. So this is the map for where you are now. Need this thing to go away. Okay. And then this is the map for where everybody's from, right? So, and if you click here, you can get the list of people's names. You can click on the pins, or you can click on, somebody's name there, and it gives you the information that I got, right? So thank you to thank you to everybody for sharing. Thank you to the group spokespeople and recorders for getting that information down and for sending it to me. And here are our maps. I think that's kind of cool. So I'll get that sent out to folks. All right, so as Bill did on Monday, another thing that we like to do during this training course, and normally we do them over lunches, but since we're not all having lunch together, we're just taking a few minutes at the beginning of each presentation for us as the faculty to just share a little bit about our career progression to date. And that's really the purpose of that, is so that, if there's somebody who has a career trajectory or experience or something like that that you're interested in learning more about, that you know who to go and talk to, because we like you and we want to talk to you about method stuff, epi stuff, career stuff, all those things. So I will just give a quick overview of mine, and then we will get into generalized linear modeling, which I hope you're as excited about as I am, because I am genuinely excited about it. So for me, my career started in the nuclear power industry. So I worked at a nuclear power plant in Oconee, South Carolina, the Oconee Nuclear Station, after I graduated from college. And the area that I worked in is an area called health physics, or radiation protection. And so for this entire nuclear power plant, everybody that works there wears a dosimeter to measure the amount of radiation that they're exposed to. And my job was to keep up with that data, the radiation exposure data, and how many millirems folks were exposed to. And that was really my introduction to public health. I didn't really know anything about public health before that. I was a mathematics major in college, and getting that experience made me really interested in biostatistics. So I went to the University of South Carolina and did a master's degree program in biostatistics. And when I was in the second year of my master's program, there was a position open with the PRAMS project at the South Carolina Department of Health and Environmental Control. And so I took that job, and my first job at the health department was literally stuffing envelopes and signing letters for PRAMS, right, and carrying things to the mailroom and picking things up from the mailroom. And I was at the health department for a little bit over 10 years in a variety of roles. I was a maternal and child health epidemiologist there for most of my time there, and I was the director of a division of research and planning that did our block grant and needs assessment stuff, that did our infant mortality reduction plan, that did our birth effects monitoring program. We had a muscular dystrophy surveillance program. maternal mortality, morbidity review, or perinatal regionalization, and things like that. And then, before leaving the state health department, I was the deputy Title V director, and I was, getting just more and more into administrative stuff, and really kind of the balance that I like is kind of 60 or so percent administrative stuff and at least 40% or more data research stuff. And I was just getting farther and farther from that. Most of the time while I was working at the state health department, I was also a graduate student because I was working in Columbia, South Carolina, where there was a university with the School of Public Health. And, I started out just continuing to take some biostats courses because I thought they would make me better at my job. And then, my advisor there told me that you really should be in a degree program if you're taking these classes, and not just, taking them, one after the other, and not getting anything, not making progress towards anything. So okay, I might or might not finish it, but I'll start this degree program. And so what I was working towards was a DRPH and biostatistics, which is kind of a strange degree to have. But basically, I didn't take some of the more theoretical courses, the statistical courses, and instead I took, you could kind of almost pick like a focus area, almost like a minor. And it could be, maternal and child health, and you could take classes from the med school or whatever, and the college school of education and, things like that. But what I focused on was epi and evaluation methods. And so I took, all the applied biostats courses and all the epi methods courses and evaluation courses. And so I thought that degree would maybe make me a better functional epidemiologist than the PhD in epi there at the time. So that's the way I went with that. And so I was a part-time student for a lot of years, slowly making progress towards that degree, kind of one course at a time, and then dissertation stuff, and finally finished it. And soon after I finished it, I found myself not doing much with data in the job that I had, not doing nearly as much, which was kind of unsatisfying. And then 3 years ago, an opportunity came up at East Tennessee State University. They'd won a big evaluation contract to evaluate a contraceptive access initiative that was going on in South Carolina. And so they approached me about coming to help lead that evaluation project. So that's what I've been doing for the past few years, and it's been great. So for whatever it's worth, whether that's interesting or not, that's what my career has been so far, and it's been a blast. I absolutely love working in public health. So if anybody wants to talk about that anymore, just please send me an email. I'd be happy to set up a time to chat. And that's absolutely true of all the faculty on this training course. As you hear our career stories and things like that, we're all happy to talk to you about our experiences and talk to you about your experiences and learn from each other that way. All right, so with that said, I'll share my screen again and pull up these slides. All right, so we've talked about some of this stuff already in the video. So, and of course, I always have to acknowledge Deb Rosenberg and Kristen Rankin because they're excellent and they've done so much good for this training course. And in all of my presentations, some of the slides are borrowed from things that they developed. If you ever have a chance to work with them, or if you ever have worked with them, you know what great people and researchers they are. So we've walked through some of these things in the webinar that we had a couple of weeks ago. We talked about some of these necessary steps really before you even pick up the data. And we went through these in the video, so I'm not going to go through them again in detail. But again, stopping to think before you get the data is absolutely essential for doing good MCH epi work and good applied research. And then we can, after we do some of these analytic steps, we can move into regression modeling if it's appropriate. Sometimes it is, sometimes it isn't. We talked about what regression modeling means, some of these underpinning things, link functions for generalized linear models, absolute and relative models, and things like that. I'm going to see if I can move all your pictures and things. I don't know if I can do that. There we go. All right. So just as a summary of some of this stuff, right, we have across the top here, these are our additive models or absolute models, right? One is linear regression, and with linear regression, what we're really looking at is means, and the measure of association that we get from our beta coefficients. Those are differences between means. With binomial regression, which we'll talk about more in a little bit, what we're really modeling is probability, right? Or the prevalence or the risk, depending on if it's a more cohort design study, we're talking about the risk. If it's really more of a cross-sectional design, then we're talking about the prevalence. But we're modeling that directly, and our beta coefficients are giving us a risk difference or a prevalence difference, depending on what type of data we have. Here across the bottom, these are our multiplicative models, right? So logistic regression, which we're probably pretty familiar with. It's a logit link, and our outcome or our measure of occurrence that we're looking at from the beta from the model, right? The whole model is the log odds, and the exponentiating the beta coefficients gives us odds ratios, right? So something that you're likely familiar with. And then also on the multiplicative scale models is log binomial regression, where we're using a log link, and we'll talk about this some more in a minute. What we're modeling there is the log probability, right? So here we're modeling the probability directly. All we're doing here is just taking the log of that outcome. So we're modeling the log probability. And when we exponentiate our beta coefficients, we're getting risk ratios or prevalence ratios. Okay, so we're going to walk through logistic regression, log binomial regression, and binomial regression. Some of you may be quite familiar with these things, but I think it'll be helpful to walk through them. So again, we're going to discuss 3 multivariable regression models: logistic, log binomial, and binomial. Again, logistic and log binomial are multiplicative models, which means we're really working on that ratio scale, right? Our measures of association are ratios. Binomial is on the additive scale, which means our measures of association is a difference, right? A risk difference or a prevalence difference. Then at the end, we're just going to talk about adjustment in some of these multivariable models, and then look at interpreting some results. All right, so let's jump into logistic regression. It has the same form, right, that all of our linear models have. This beta intercept, beta coefficient, plus parameter estimate beta, and then our data here, right? The value of the variables that we're working with. The outcome is the log of an odds, right? So the odds is the probability divided by 1 minus the probability. We're taking the log of that, and we can get the predicted values that we get if we're using the whole equation. We're predicting the log odds, right? And if we are interested, so our parameter estimates, right? A single parameter estimate, the beta coefficient is the change in the log odds for every unit change in X, if we're using a continuous variable. here with beta 1. If we're using a categorical variable, right, like a 2-level variable, then it's 1 minus 0, so it's 1. So it's just beta 1, and then you would exponentiate beta 1. What this shows us is on this scale, if we have the log on the left side of the equal sign, right, this intercept term, we have a positive intercept term and a negative intercept term, and they'll cancel out. If we're on the exponentiated scale, right, we've exponentiated both sides of this equation, right? So we have just the odds over here, and we have the exponentiated model on the right-hand side of the equal sign. Then we have e to the beta naught, e to the beta naught, and those cancel, leaving us e to the beta 1, right? So that's what we're interested in for an odds ratio. With a 2x2 table, you may well remember the formula. It's very easy. It's A times D divided by B times C. Really, it's this P1 divided by 1 minus P1, right, which is here, divided by P2, this 56% divided by 1 minus P2, which is there. And if we do some algebra, right, we can simplify that down to A times B divided by A times D divided by B times C. The example that we're going to be working through really throughout these slides and the slides on Friday is this MCOA and postpartum visit example. So the outcome that we're going to be looking at is a postpartum visit, and this is from Medicaid data. So the outcome is a postpartum visit, yes or no. After the woman had a baby, did she have a postpartum visit? And what we're using to try to quote unquote predict the postpartum visit is which managed care organization the woman was a part of. So as you may know, many Medicaid programs, state Medicaid programs, are moving away from fee-for-service and have moved away from fee-for-service to a managed care framework. And that's where basically a managed care organization kind of functions like a Medicaid insurance company, and they're getting a capitated rate. So they're getting a kind of a flat rate per patient to manage their healthcare needs, right? And so different MCOs can have different strategies for managing their patients' needs. So there could be differences across MCOs in service utilization and health outcomes and things like that. So what we're looking at here and what we're asking is, are we seeing a difference in the outcome postpartum visit across different Medicaid MCOs? All right, so the one that we're primarily interested in is this MCOA. So for MCOA, 41% of the women get a postpartum visit after delivery, and all the other MCOs, 56.6% of the women have a postpartum visit after delivery. So what we're trying to understand is, is MCOA different than these other MCOs? And if so, how different, right? How do we quantify that? And so if you do this odds ratio calculation from this 2x2 table, right? That's cell phone math. You can do it on your cell phone. It's not hard. It's nothing statistically complex or anything like that. Cell phone math. You get, and you can do the frequencies, right? You can try it both ways. Do that 6,000 times 17,000, over those frequencies, or you can do the percentages. Either way, it should work out to this 0.5322, right, as the odds ratio, and then confidence interval around that odds ratio, right? We expect it to be, we see based on these proportions that women in MCOA seem to be perhaps less likely to get a postpartum visit than women in other MCOs. And this odds ratio backs that up, right? It says that the odds of having a postpartum visit for women in MCOA is 0.53 times the odds of having a postpartum visit for women in other MCOs. And we have a confidence interval that does not include the null value, right? For a ratio measure, the null value is 1. It does not include that null value. So we might conclude that that's significant. But so this is pretty easy analysis to do with a 2x2 table, right? We just have two dichotomous variables. We can very easily replicate these results from a logistic model, right? And using SAS here. So this is the SAS code that we use to do this same thing, and it gives us an intercept and a parameter estimate, right? And if we want to get that odds ratio, all we need to do is exponentiate this parameter estimate, right? And that gives us 0.532 from 512 to 553, right? The same results that we get from the 2x2 table, we get from the logistic regression model. Right, and then this is the interpretation that we just talked about. This makes sense? This is familiar to everybody? Mostly familiar?
Yes.
Okay, good.
You can utilize the chat function or unmute yourself if you're on the phone, *6.
All right. So I see everybody saying yes, 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 yes.
Yes, they're coming through the chat.
All right, cool. All right, so this is modeling the log odds, right? And we're looking at odds ratios. Okay, so that's one thing that we can do. We could also use log binomial regression. And as I mentioned, with log binomial regression, instead of modeling the odds, we're really modeling that probability, the log of the probability or the log of the prevalence, right? So it's instead of the probability divided by 1 minus the probability and taking the log of that, we're just taking the log of this probability. So the way that we implement this in SAS is ProcGenMod. That's what we use. GenMod is flexible and can be used for any generalized linear model. So we could run logistic regression here through ProcGenMod or linear regression through ProcGenMod. All we have to do is we do ProcGenMod, our data set name, class, and our categorical variables, model our outcome, our covariates, and then we do this option slash, and we say link equals log, right? Because we're taking the log, and distribution equals bin for binomial, right? So that's what we're saying about the relationship between the errors and the outcome. So to implement log binomial regression, it's really easy in SAS. You just have to know to use ProcGenMod and then link equals log, dist equals bin for binomial. So the predicted values from log binomial regression, instead of the log odds, they're the log of the prevalences or the risks. The measure of association, right, the beta coefficients that we get are the differences between those log risks or log prevalences. When we exponentiate those beta coefficients, it'll give us the estimate of the relative risk or the relative prevalence, or the risk ratio or prevalence ratio. And it works out very similar to the way logistic regression works out, mathematically. So we don't have to walk through that. But here we just have the log of this prevalence or risk on this side instead of the log of the odds on the left side of the equal sign, right? And then those cancel. And so we're left with just that beta coefficient, and we can exponentiate to get the prevalence ratio or the risk ratio. All right, and if we have a continuous variable, right, instead of just 1 minus 0, it's whatever values we're interested in, value A minus value B for a continuous variable. Of course, we have confidence intervals. What we're going to see here is crude log binomial regression is a modeling version of a 2x2 table. Right? So the outcome and if the outcome and the exposure are both coded 1, 0, right, we can put it together just like this P1, which was 41% in the example that we had before. If we exponentiate beta naught plus beta 1, then we get that P1. Here is just 1 minus that. P2 is just e to the beta 0. Right, so this is the same 2x2 table that we had before, right? To get the relative risk, we're just going to divide this 41%. We're going to have 41% divided by 56%, right? Again, cell phone math, not hard. And it gives us this value, right? 0.724, right? With a confidence interval that goes from 0.71 to 0.74. We can get the same information from our SAS code here. We use proc GenMod, again, class MCOA, because that's our categorical predictor variable. Model the PP visit variable. MCOA is our predictor variable, and then link equals log, dist equals bin, right? And these are the parameter estimates that we get. So if, say we can't remember if we need to just exponentiate this, just this main effect for MCOA, or if we need to do the whole model, right? The beauty of understanding what these regression results are is that you don't have to memorize, do I include the intercept or do I not include the intercept or what? You can write out what you want to compare. So write out the full model, right? You have the intercept, plus the parameter estimate for MCOA, right? And we want to compare folks who were in MCOA compared to folks who were not in MCOA, right? So here it's MCOA parameter estimate times 1, because we want folks who are in MCOA, divided by the whole model, right? Do the intercept term plus the parameter estimate for MCOA times 0, because we want folks who are not in MCOA, right? That parameter estimate is times 0, so it goes away. Then we have this 0.5684 on the top and the bottom, and those will cancel out. And then we're left with just the exponentiated parameter estimate, right? So we don't have to memorize it. We can take, a minute and a half to write it out, and that saves us from having to memorize things. If we find ourselves in a situation where we haven't done this in a while and we can't remember what the right thing to do is, you can always write it out. And if you understand your model and how it's working, right, that's the important part. You really want to know what's going on under the hood of your analyses. And if you know that, then you can work through these things yourself. Okay, so this gives us that 0.72 when we exponentiate there, right? The same risk ratio that we had from the 2x2 table. Now, because GenMod is flexible to run a lot of different types of models, it doesn't exponentiate your betas by default. You can write an estimate statement to do that for you in SAS, and so it is the same proc GenMod that we had before. Link equals log, dist equals bin. We say estimate, and then we give it a title. Right? We put our title in quotes. This is what it's going to call it in the output, because we can write 5 estimate statements, and we want to be able to know which one is which. So we give it a title. So this is the relative risk exposed versus unexposed. And then all we need is our exposure effect, right? Our parameter estimate for our exposure times 1. And then we do /exp when we're telling it to exponentiate this coefficient, right? So this is what it looks like for our model. Right? Estimate, I want the relative risk, MCOA versus other MCOs, MCOA times 1, exponentiate it. Right? And that, I thought I put those results in here. But, all right, but that gives us the results that we're looking for. It gives us that risk ratio. It gives us the confidence interval. It gives us exactly what we want. Some drawbacks to log binomial regression. The big benefit is we're modeling exactly what we want. In most cases, we're modeling the risk ratio or the relative risk, and that's usually what we want, right? If we're using logistic regression, we're using it because we think that it's going to give us a good estimate of the relative risk, that we think the odds ratio is going to be a good estimate of the relative risk, and that's why we're using it. Because that's usually how we think about an odds ratio. We don't have to do that. We can actually model what we want to use, right? That's the big benefit of it. some drawbacks is that the log binomial model is just not as stable as the logistic model. Sometimes it doesn't converge. Sometimes the confidence intervals are a little bit narrower than they should be, and sometimes the estimated probabilities derived from the model, they might not all be between 1 and 0, right? You could get an estimated probability that's above 1 or below 0. That's usually not a problem with ratio measures, but be aware that that can happen. So those are the big drawbacks of using log binomial regression as opposed to logistic regression. Some things that you can do to try to address those convergence issues, right? If your log binomial is not converging, in this model statement, in your options here, link equals log, dist equals bin, you can say intercept equals -4 or something else, right? You can give the model somewhere else to start. And sometimes that'll help it get to a place where it can converge. If that doesn't work, you can use what's called modified Poisson. So that's Poisson regression with robust standard errors to approximate log binomial. So again, that's called modified Poisson. You want to generate robust standard errors when you're using modified Poisson. So that means you have to have a unique ID number in your data set. So if you have individual level data and you don't have a unique ID number, then you can create one using this _n_SAS system variable to give you your unique identifier to get your robust standard errors. So I'm going to show you the code to do this. And so it's procgenmod also, and then your model statement, link equals log, dist equals Poisson, right, instead of binomial. And then in this data set, we had a beneficiary ID, right? So that's our individual identifier variable. So we just use this repeated statement, right? Repeated subject equals beneficiary ID, type equals independent, IND. And that gives us our robust standard errors, right? So if we don't account for that, then our confidence intervals will be too narrow. So we want to use this robust standard error when we're using procgenmod for a modified Poisson, and then we can use an estimate statement just like we talked about before. And it gives us basically the same results here that we got from the log binomial, right? This -0.5684, right? And this is what we got from log binomial, from log binomial, -0.5684. For MCOA, we had -0.3229, right? -0.3229. We get the same thing with modified Poisson. Our estimate statement gives us our risk ratio and our confidence interval, right? So 71 to 74 for our confidence interval. That's what we calculated from the 2x2 table way back here, right? 71 to 74 for the confidence interval, 0.724 for our risk ratio from the 2x2 table. Right? We can get that pretty easily from log binomial. We can also get that pretty easily from modified Poisson, right? And here we're modeling the risk ratio. So our interpretation, right, this 0.72, women with Medicaid paid deliveries in home state who are served by MCOA have 0.72 times the risk, or a 28% lower likelihood of receiving a postpartum visit compared to their counterparts served by other MCOs, right? So we have 0.72 from log binomial or modified Poisson. We had an odds ratio of 0.53 from logistic regression. Right? Are these particularly close to each other? And usually what we're going for when we have an odds ratio is that it approximates the relative risk. But does this odds ratio do a good job of approximating the relative risk? Is 0.53 the same as 0.72? Yeah, people are saying not really. No. No, it's not. Why is that?
Feel free to unmute yourselves as well, or utilize the chat function.
Why is, yeah, so Amy Poole, not a rare outcome. Yeah, so if I run back up to our 2x2 table way back here, right? The outcome postpartum visit, 41% in MCOA have the outcome, 56% and the other MCOs have the outcome, right? This is not a rare outcome. And one of the assumptions that we really make, if the odds ratio is going to be a good approximate of the relative risk, is that the outcome is rare or rare enough, depending on the effect size. So sometimes the odds ratio is a liar, right? And it doesn't give us what we think it's giving us. I'll tell you, I don't like the odds ratio and logistic regression. Well, logistic regression, there are some ways you can do it, but I don't like the odds ratio very much at all. I think that it's, not usually what we want. Sometimes it's approximating what we want and then it's useful, but it gets used a lot when it's not approximating what we want. Like in this scenario, it's not giving us the right answer. And if we had just run a logistic regression, we would have the wrong answer. We would think that MCOA makes a bigger difference than it actually does, right? It's biased away from the null, the odds ratio here. So in your Google Classroom here, right here in week 1, right? So here's the top of it. Scroll down to week 1. Down at the bottom of week 1, there's some helpful supplemental materials. Right? If we open these helpful supplemental materials, there's a supplemental video that I posted called "Down with the Odds Ratio," and that's where you can get some of my thoughts and things that that I've benefited from learning from other people about the odds ratio. And it's, I think, a 12 or 13 minute video of me railing against odds ratios. So if you want to hear more about that, you have that opportunity. That's the place to find it. All right. So this stuff with log binomial regression and modified Poisson regression, does this make sense? Is useful?
Couple yeses coming through the chat now. A question, do you have links to the background information?
Yeah, so some more background information. Yeah, so there are some really good resources for some more background information. I think I put some of them at the bottom of some of these slides. If I can get my slides to move again. Like this Donna Spiegelman article is really helpful background information. There are a few other good articles. I can post them to the Google Classroom that are helpful. And I think that I later in this presentation have some other articles that I reference.
Another question, would you try adjusting the intercept before going to modified Poisson?
Yeah, so I would I would try to set the intercept at -4 or something like that before doing modified Poisson, just because that if it works, then it's a little bit more efficient. If it doesn't work, it's not, you haven't lost much, right? A few keystrokes and you clicked run and it took a few minutes to decide that it still couldn't converge. Yeah, so I would try that. And I do try that first, right? Because there are times when log binomial just doesn't converge. I try that first and then go to modified Poisson. Yeah, so Vito, I see your question, how's the data need to be structured at individual level? So it depends on how you're wanting to analyze it, right? So with this Medicaid data, it's individual level because I'm just looking at the postpartum visit outcome. If you're looking at across all of their healthcare encounters, did they, ever have this diagnosis or something like that? Then it could be kind of at the visit level, or you could, in GenMod, using that repeated statement, right? You could set up a generalized estimating equation to set up a multi-level model, right? And you can do the same thing at a multi-level model if you have other kind of sub-individual levels that you want to account for, or if you have higher than the individual levels, right? Some community level factors that you want to include. So that's a good thing about GenMod, is that it's flexible enough to be able to handle longitudinal data as well as individual level data. Does that answer your question, Vito? All right. Okay. So those are regression models, right? Logistic regression, log binomial regression, where we are looking at a ratio measure, right? So those are multiplicative models. Now, a lot of times, so the ratio measure, right, in this case, it's, telling us, 0.72 times or 28% lower likelihood. That gives us some information, but that also doesn't give us some information, right? If it's, if the probability of having a postpartum visit is really high for the other MCOs, and it's also really high for MCO A, but it's a little bit less, right? That's a different situation than if it's really low, the probability of having a postpartum visit is really low for all MCOs, and it's even lower for MCO A, right? So all this is giving us is some relative information. It's just, compared to the other MCOs, MCO A has a lower postpartum visit rate. We don't know what they are, right? With this, we can calculate that from log binomial, but we're not modeling that exactly. So this is giving us a ratio measure. Sometimes what we want is an absolute measure, right? What is the predicted probability of having a postpartum visit or the predicted prevalence of having a postpartum visit if a woman is in MCO A compared to other MCOs? Sometimes we don't want a ratio. We want that prevalence estimate or that risk estimate. So to get that, we can use binomial regression, right? So we're just modeling, excuse me, we're modeling this risk or this proportion or this prevalence directly, right? So this is, you can think about this more like linear regression, where you're modeling the mean directly, right? And you're not exponentiating your parameter estimates. You're using your parameter estimates directly as the difference between means. Here, you're using your parameter estimates directly as the differences in the prevalences or the differences in the risks, right? And this situation that we're looking at here with MCOA, it's the difference in the prevalences. So the link that we use is identity, right? Because we're not taking the log of the outcome or anything like that. So we don't need to exponentiate. So the link is not log, the link is identity. The dist is bin for binomial, right? Other than that, our GenMod looks the same. And we have class, our class variables, our outcome, our exposures, our option, link equals identity is the thing that we're changing here. And again, the measure of occurrence, right? The predicted values that we're getting are the risks or the prevalences, right? So if we use our regression equation, including the intercept, then our predicted values are the risks and the prevalences, right? And so that's our measure of occurrence, our measure of association, right? If we want to compare things this is an additive model, right? The binomial model is an additive model, so we're subtracting instead of dividing. So we just have the risk prevalence for one value minus the risk or prevalence from another value. And if we use the full equation, right, our intercept plus our parameter estimate minus the intercept plus our parameter estimate for this other value that we care about, then we have a positive intercept and a negative intercept, and they cancel, right? And we're left with just the parameter estimate here, right? So just like in logistic regression and log binomial, if we are looking for the measure of association, what we're interested in is just the parameter estimate. Again, we don't have to memorize that if we understand what our data has given us. We also calculate confidence intervals. And then in a 2x2 table, right, if we have the outcome and the exposure both coded as 1, 0 for yes and no, then this proportion 1, P1, is the intercept plus the exposure parameter estimate. P2 is just the intercept. And so here is the same 2x2 table that we're used to looking at, right? P1 is still 41% of MCOA, women enrolled in MCOA having a postpartum visit. 56% of women enrolled in other MCOs having a postpartum visit. Right, and if we take that difference, 41% minus this 56.6%, we get negative 15.63%. Right, again, cell phone math. Easy stuff. Right, so all we're saying is women enrolled in MCOA have a 15.6 percentage point fewer postpartum visits than women enrolled in other MCOs. And we can easily get these numbers very easily from the ProcGen mod, right? Link equals identity, dist equals bin. This intercept, what did we say up here? The intercept is just this P2. Right here, the intercept 0.5664, 56.64, right? 56.6%. That's what the intercept gives us. The risk difference, negative 15.63%, right? Negative 0.1563 is what this parameter estimate gives us. Right? If we take the full model with the intercept and this MCOA parameter estimate, we have 0.5664 minus 0.1563, that gives us 41.01, right, or 0.4101. So we can calculate our full 2x2 table, right? We can replicate it from our unadjusted model results here, right? And when we understand what these parameter estimates mean, we have a lot of I don't know if power is the right word, but yeah, I mean, we can really do a lot with our regression results when we really understand what our parameter estimates mean. And I mean, I hope that this is a good illustration that it's not magic, it's not complicated, right? It's in an unadjusted model where the outcome and the predictor are both dichotomous. Right? We can easily replicate this 2x2 table from our model results. And so the interpretation for this risk difference is that women with Medicaid paid deliveries in home state who were served by MCOA have a postpartum rate that is on average 15.6 percentage points lower than their counterparts served in MCO and by other MCOs. Right? So sometimes this is the interpretation that we want, right? We don't want to say women with Medicaid paid deliveries in MCOA have 0.72 times the rate of postpartum visits compared to their counterpart served by other MCOs. Sometimes that's not as useful. If we can say 15.6 percentage points less, that resonates with people, especially if you're talking to a non-statistical audience, right? I mean, this is statistical analyses. You're doing a model, it can be kind of fun, but if you can present the results in terms of percentage points, that's stuff that people can understand, right? You know, sometimes you're presenting to an audience that, you know, has physicians and nurses and social workers and community health workers and lawyers and, you know, whoever. in the audience, and you need stuff that's understandable, but people intuitively understand these absolute differences, very clearly, and you can, do all the adjustment, and you can do multi-level stuff and whatever, and present to them an absolute difference of 15.6 percentage points, right? And it's understandable. Just because your analysis is complicated doesn't mean that your results and your presentation and your delivery of those results has to be complicated. Again, if we care about the programs that we're serving and we care about the populations that those programs are serving, we want to be as clear as we can, right? Doing the fanciest analysis that we can do. If we can't explain it to anybody that has decision-making authority or a group that is, deciding on policy or program issues, right? If we can't explain it to those folks, the best case scenario is that it's exactly useless, right? It could be that they misunderstand the complicated stuff that we're trying to explain to them because we're not doing a good job of communication, and they're making bad decisions with the data that we're giving them. Right. So again, I know I talked about this a couple of weeks ago, but it's, that communication is so important. And if we can have really intuitive results like this that are easy to communicate to broad audiences, what a good situation, in my opinion. All right. So we already talked about this, but just a quick recap. This intercept 0.5664, what does that mean? Is that the postpartum visit percent for MCOA, postpartum visit percent for other MCOs, the risk difference for MCOA versus others, or something else? Or you don't know? Somebody tell me. All right, I've got people saying B. Everybody's saying B. Yeah, good. Good. I'm glad. All right, so yeah, so like we just saw, it's this 0.5664 is just this 56.64 here from our 2x2 table, right? It's nothing magic. It makes a whole lot of sense. All right. Here's some, somebody, I don't remember who it was asking for other links, right? Here's the UCLA link for log binomial regression, which is, all their stuff is super useful. There's a SAS macro to produce relative risks and risk differences from logistic regression, right? That's why I kind of hedged a little bit earlier when I started to say I don't like the logistic regression. There are some good things you can do with it, just not presenting odds ratios. But this is a useful SAS macro. And then Jay Kaufman and Ashley Harai did really excellent several years ago in HRSA and Rich webinar about this stuff, right? Estimating absolute differences and relative rate ratios from regression models. So I recommend checking that out if you want to go deeper into this stuff, because that's really good. All right, questions about this, about binomial regression? Is this useful?
Yes, it is useful.
All right.
I don't see any questions yet. One question, survey data with a weight, is there a specific SAS syntax?
Yeah, so it's tougher to do this in SAS with a weight, in my experience, unless something has changed in SAS. There's a macro out there that can help. It's easy to do in Stata with weights, and you can do some really good stuff in Sudan if you're using Sudan, like SAS callable Sudan for weighted data to do predicted marginals, and you can get these differences. I'll show you here in the in the useful, helpful materials here. I don't know if you've seen it or not, but I've posted some, oh man, okay, some sample SAS code and Stata code for this stuff, right? So we're, this is binomial regression with a bunch of estimate statements, log binomial with a bunch of estimate statements, all kinds of different situations. Here, so this is how to do it in Sudan. This is a link to the macro. It should be embedded. There should be a PDF embedded in this document when you open it for real that gives that SAS macro. And again, in my experience, that's kind of difficult to implement. But SAS may have put something in by now for doing it with weighted data. All this code is also here as Stata code, right? To do all these different things. If you like to use Stata instead of SAS, I use SAS and Stata. I don't use R. I think Michael Kramer, he may be on this call. He uses R a lot, I believe, based on a previous webinar that I've seen. So maybe he can do some of this stuff in R, but that's not something that I use very much. But I want to let you know that this is out there. Hopefully this is a good, helpful resource with a bunch of SAS code and Stata code.
Okay, another question. Are there rules of thumb for sample size / cell size considerations?
Yeah, I mean, there are always things to consider with sample size and cell size. So, having really low sample size, having really low cell sizes can always cause things, at least in my experience, and maybe others know better, always cause things to blow up when you're in a regression situation, especially if you're adjusting for a bunch of different confounders and things like that. So, having to use, some other techniques that maybe work better for small sample sizes and that are, in a lot of ways, just doing some more straightforward things with your analyses might be better in that situation. But I don't work with a lot of really small sample data, so I'm not the best person to ask that question, honestly. So if someone else here may know more about that than I do, please feel free to speak up if you do. But in my experience, when things get small and cell sizes get small, that almost always causes issues. Anybody have anything they want to say about Vito's question here? Okay. All right. I'm not hearing anything. I'm going to keep going a little bit more. All right. So now let's talk about, we've gone through these, unadjusted models, right? And now we have a really good understanding of how logistic regression works in an unadjusted model, how log binomial works in an unadjusted model, how binomial regression works in an unadjusted model. We understand how they relate to this simple situation with a 2x2 table, and everything is making good sense, right? Now, the benefit of using ProcGenMod, right, a generalized linear model, instead of using 2x2 tables, is that you can adjust for potential confounders and effect modification and things like that, right? So let's talk about how we do that. This is stuff that you may be very familiar with, but just kind of from a conceptual perspective, if you want to model a categorical independent variable, right, a predictor variable with more than 2 categories that is nominal, right? If you don't want to analyze it as an ordinal variable, right, you want to analyze it as a categorical variable, but it has more than 2 categories, right? So for example, if you want to model 3 categories of race ethnicity, African American, Hispanic, and white, right? For log binomial, you're doing the log of the risk for white women, the log of the risk for Black or African American women, the log of the risk for Hispanic women, and if we were looking at postpartum visits, right, they would be women. And then for the binomial model, you're just looking at just the risks. You're not looking at the log. So what you don't do is put this 3-level race ethnicity variable in your model statement just directly, right? Because that treats it like it's a continuous variable, and like going from one race to another is like a continuum, right? So for every unit change in race ethnicity, there is a whatever change in the log risk of the outcome. And so what we do is, and what the model does, is it tricks the modeling procedure into handling this nominal variable appropriately by creating dummy variables or indicator variables, right? So it's really a set of dichotomous variables. It takes this 3-level variable and it creates 2 dichotomous variables from it. So if we have K categories, in this case we have 3 categories, it constructs a set of K minus 1, or in this case 3 minus 1, 2 dummy variables to capture this construct. And then if we calculated all 3, then we would have redundancy in the model. If we calculated 3 dummy variables, we just need 2 of them. So for this one, we can create this African American variable and this Hispanic variable, where African American is 1 if race ethnicity is African American, and then 0 otherwise. And then this Hispanic variable is 1 if race ethnicity is Hispanic, and 0 otherwise, right? And so byte is 0 for both of these variables, so it's the reference group, right? And if we're using SAS, we can create these dummy variables like this, right? If race eth equals 1, that's African American, then we create this African American variable that's 1, and it's 0 otherwise. And we can create 3 of them, but we only want to use 2 of them. Whichever one we leave out is going to be the reference, right? So then we could use procgenmod and include both of these variables, and then the white population would be the reference population, right? So kind of conceptually, this is what happens when we use a class statement in SAS, or we use like the I dot or something like that in Stata. So we say race eth ref equals white, and then we do model, and then we include race ethnicity here, right? This is how you usually do it in practice, right? You use a class statement and then you put the 3-level factor in there. But what the results give you, right? You have a reference value, and it's basically if you had broken these into 2 dichotomous variables, right? So conceptually, that's what's going on, is you're breaking things down into 2 conceptual variables. So again, that's stuff that you probably know, but I just want you to think through that with me quickly. And so I want to check in again. Does that make sense?
A question, do the categories have to be mutually exclusive?
So for something like this, yeah, the categories need to be mutually exclusive, right? And so for race ethnicity, as like in real life, race ethnicity, it's not mutually exclusive. So maybe this is not the best example to use, but from a statistical data standpoint, yeah, they need to be mutually exclusive.
Others are saying that this is helpful.
Okay, cool. All right, so what I would like to do now is just take 15 minutes into a breakout group, and let's walk through in here in the Google Classroom. If you click on exercises for linear modeling sessions, right, and open this first one, right, there's an exercise here, and we'll just do this first one here. So it's kind of putting these things together. It has the variables in a little data dictionary. It has the code where we're doing log binomial regression. And instead of having MCO-A compared to all the other MCOs, we have MCO as a four-level predictor variable. We have MCO-A, B, C, and D, and we have the parameter estimates for that. And so let's just work together and interpret those parameter estimates quickly. So let's take 15 minutes, go into breakout rooms, and work through that. You should be able to find it on the Google Classroom. And if everybody can find it, you can work through it on your own in your group, or if somebody wants to pull it up and share their screen, that might be a good way to do it too. All right, so Ashley, can you help break us out?
Welcome back, everyone. Hopefully, maybe we have everyone. Let's see. Looks like we are almost, yep, we are good.
All right, so when I was bouncing around some of the breakout rooms, and I've stopped in almost all of them, I realized that I was not very clear at all in what I was asking you to do. I showed you where this, where that document was, and I was not very clear that, for now, just do number one. Just do problem number one, right? So if you were getting to a place where you're doing model 1B and model 2, you're going too far. We're gonna look at 1B in just a minute. So you weren't way ahead of me there. If you were looking at interactions, I'm sorry, we haven't talked about that at all. We're gonna talk about interactions on Friday. So if that was confusing and hard to think about right now, don't worry. We will talk about it, and hopefully it'll be crystal clear on Friday. So I'm sorry about that. And this is one of the downsides of having virtual breakout rooms, right? If we'd broken up in different areas of the same physical space, I would have realized that failing on my part much more quickly, and could have addressed it much more easily. So I'm sorry. But for number one, right, where you're just looking at MCO A, B, C, and D, and the association with postpartum visits, what do you think?
It's a great opportunity to unmute yourself, maybe have the video on, so you can get some great engagement from you all.
So how did you approach that?
Well, it looks like compared to MCOD, A, B, and C all were associated with a lesser likelihood of postpartum visits. But C was,
So why are you comparing to MCOD?
that was the reference.
Okay, and how do you know that that's the reference?
Well, part of it was the param equals ref in the code, and then it's not shown in the output.
Right. So in the output, right, you have MCOA, and that's basically a dummy variable comparing just MCOA to MCOD, right? And so MCOB, that parameter estimate, is really just a dummy variable comparing MCOB to MCOD, right? And MCOC, that parameter estimate, is really just a dummy variable comparing MCOC to MCOD. All right, cool. So that's why D is the referent. So when you compared MCOA to MCOD, right, what measure of association did you calculate?
Was the risk ratio.
Yeah, a risk ratio. And how did you calculate that risk ratio to compare MCOA to MCOD?
Well, I didn't actually do it, but you would take the exponent of the estimate, right?
All right, so e to the negative 0.232,
Yes.
right? All right, so e to the negative 0.232. And what do you get when you do that?
It was point,
Right.
we got 0.79.
Yeah, 0.79. All right, so what does that mean?
That means that for individuals with MCOA, compared to MCOD, if you adjust for B and C as well, that their risk of postpartum visit is 0.79 times that. The sentence is off, I'm thinking it out loud, but times that compared to MCOD participants.
Yeah, no, you're exactly right. You're exactly right. And Jan typed it in to the chat, a good interpretation. Yeah, so that's it. So that's, a risk ratio of having the risk, right? This is the prevalence of having a postpartum visit for women in MCOA is 0.79 times the prevalence of having a postpartum visit in MCOD. And then for MCOB versus D, what is your relative risk or relative prevalence, actually, since this is cross-sectional data? What did you get comparing B to D?
0.38.
.38. Let's see, I have here in the chat 0.91. So how do we get that 0.91? Somebody tell me.
You take the estimate and you exponentiate it.
Yeah, exactly. So yeah, Chandra says you exponentiate negative 0.096. Right, so when we're comparing B versus D, right, B, the postpartum visit rate for women in MCOB is closer to D than the postpartum visit rate in MCOA, right? 0.79, 0.91. And then for MCOC versus D. What do you get, right? We exponentiate negative 0.019, right? That's the parameter estimate for MCOC. And that gives us, as Chandra says, 0.981. Right, so is there really much of a difference between women enrolled in MCOC and women enrolled in MCOD? No, there's not much of a difference, right?
No.
That 0.981 is quite close to the null value of 1. Right, okay. So this makes sense? All right, you can all do log binomial regression. Congratulations. If you haven't done it before, that's a big deal. All right, so let's talk about adjusting for other variables, right? So we talked about doing those dummy variables. Let's add in some additional variables so that we have a multivariable model. All right, so this is the picture of a woman who is worried about the effect on her unborn child from the sound of jackhammers. Right? What else do you notice about this picture?
She's smoking.
Yes, she's smoking a cigarette, and she's worried about the effect of the sound of jackhammers because they're doing road construction out in front of her house. Worried about the noise from the jackhammers and the effect on her unborn baby. So if we are going to, to model this situation, right, statistically, and say the outcome is low birth weight, and we want to try to understand what the effect of jackhammers is on low birth weight, adjusting for cigarettes, right, cigarette smoking, we need to consider both of those variables at the same time, right, to know after adjusting for cigarette smoking, is it really jackhammers that's causing any effects in terms of preterm birth or whatever on this unborn child, right? Makes sense. Sometimes we need to think about more than one variable as potential predictors, right? Yeah, the bigger issue is her anxiety level. She may be smoking to self-medicate. Awesome, I love it. Oh, sorry, Sarah. Somebody's saying that the issue might be her anxiety level, that the jackhammers are causing her anxiety. That's absolutely right. That's great. That's really good thinking. That's good public health thinking. Sometimes we need to consider more than one variable here. So we have this postpartum visit rate on MCOA, postpartum visit rate for other MCOs, and we want to account for neighborhood poverty, right? So maybe neighborhood poverty has an effect on the postpartum visit rate, and maybe it changes the association between MCO and postpartum visit when we consider neighborhood poverty. So let's look at low poverty neighborhoods. The postpartum visit rate for MCOA is 46.5%. In low poverty neighborhoods, the postpartum visit rate for other MCOs is 57.3%, right? And then we can get a risk ratio by dividing those of 0.81, right? Our crude risk ratio was 0.72. So for moderate poverty neighborhoods, the postpartum visit rate for MCOA is 44.8%. For other MCOs, the postpartum visit rate in moderate poverty neighborhoods is 57.9%, right? And 0.77 is our relative risk. For high poverty neighborhoods, the postpartum visit rate for MCOA 41.3, for other MCOs 49.1, and we have a slightly different relative risk. And then for very high poverty neighborhoods, the postpartum visit rate is 36%, and for MCOA, and 52.3% for the other MCOs, right? So we have different relative risks across the strata of neighborhood poverty, right? And we can combine those into an adjusted relative risk, right? This is using the Cochran-Mantel-Hensel formula to create an adjusted relative risk of 0.79, right? Taking into account neighborhood poverty. And we're comparing that to the crude relative risk of 0.72. And is this the same, or is this different? Is it similar enough, or is it different enough to consider neighborhood poverty a confounder in this relationship between MCO and postpartum visit, right? Generally, the standard operating procedure is to look for anything that is more than 10% different, right? So we're looking for a change of 0.7 or more, and that's really exactly what we have. This is, a change of 0.07. So this is 0.07 units higher than the crude relative risk. So we would probably want to consider neighborhood poverty as a confounder, and we would want to present an adjusted relative risk, right? So this is how we would do it if we're kind of taking the 2x2 table approach, right? Stratifying our contingency tables across the levels of a third variable. From a modeling perspective, this gets really difficult once you keep adding variables, right? So this is one outcome and two predictor variables, which is not too bad to work through, but once you start adding more and more, it gets harder and harder. So we want to a lot of times use a regression model to account for that. So this is if we put these variables in a log binomial model, right? So we're doing GenMod, we're doing link equals log, and we're doing dist equals bin for binomial. And then we're doing MCOA. The only difference is we're putting in this POVCAT4, right? This 4-level poverty. And we have our parameter estimate for the MCOA variable. And if we exponentiate that parameter estimate, we get 0.79, right? The same thing that we got here from our contingency table analysis. We can exponentiate these confidence intervals, these confidence limits, right? And get 0.77 to 0.81 as our confidence interval, which is the same thing we get here from our contingency table analysis. So this is using log binomial, right? This is the multiplicative model. This is the ratio measure. Just note that there's not an adjusted difference measure from contingency table. So if we're doing binomial regression, right, and we're looking at risk differences or prevalence differences instead of ratios, then there's not a good like Cochran-Mantel-Hensel adjustment there. Let's see. So comment from Amy, trying to remember graduate training several years ago, looking at modeling, generally didn't look at the covariate to decide if a variable was a confounder. Yeah, urge to look at the literature to determine confounders and keep them in the model, no matter the measure of association. Yeah, so yeah, this is a really good point that Amy is bringing up, and there are different approaches to model building, and a lot of times, well, not a lot of times, every time there's a lot of art to building a statistical model. And as we talked about in a couple of weeks ago in the first webinar, and I also talked about this in the video before this session, that I'm a big proponent of having conceptually driven models. And this is something that we'll talk about more on Friday too. Having conceptually driven models, and one way that I like to do it is using DAGs, directed acyclic graphs, to develop a conceptual model to understand confounding, and those are determined by the literature. Now there are some approaches where you can statistically try to assess confounding, right? It's significantly associated with the outcome. This third variable is also significantly associated with the predictor, and it's not on the causal pathway. Then it's a potential confounder, and then you can look at this adjustment like we're doing here to try to assess confounding. Now, you can overfit your models by putting too many things in there. Sometimes you're actually adjusting for things that you shouldn't be adjusting for, and you're messing up the true relationship, which is one reason it's important to try to draw out those directed acyclic graphs, again, in my opinion. I'm not the world's foremost expert on this stuff, on model building. There are some really great articles out there from folks like Sandra Greenland and others that do an excellent job of addressing model building, and and stuff from Ken Rothman on directed acyclic graphs and the best ways to incorporate those. But that's really an ideal approach, but sometimes you need to try to get a more parsimonious model, right? You need to, you need to, if maybe you don't have a lot of data, or maybe you don't feel great about the state of the evidence in the literature, and you need to statistically assess some of these confounders. Let's see. Okay, so Pat, I would support that idea if we're very confident in the literature. Yeah, I find that many MTHF articles overadjust, identify unnecessary confounders. Yeah. So again, there's a lot of art and decision making that you have to that you impose on the data as the data analyst, right? It's not a straightforward a straightforward model selection handbook. That's one of the reasons, again, that you need to understand the subject matter that you're working in and the literature around where you're working, and you also need to understand these statistics and these modeling approaches and what your parameter estimates are telling you, right? And to me, it's easiest to understand by relating it back to what it means in a 2x2 table or a stratified 2x2 table like this. So, so again, that's why I'm going this way. We're going to talk about this more on Friday. So absolutely, let's keep talking about this, but we're going to definitely talk about it more. And I'm almost out of time. So I'm going to keep walking through this so that we can finish this up. All right. Okay. So we calculate the same adjusted relative risk and confidence interval that we had from our contingency table analysis. We can do the same thing with binomial regression, right? And get an adjusted risk difference by including our potential confounder there, right? And it's 11.5 percentage points different. Again, adjustment in multivariable models, covariates may not empirically perform as confounders, but there may be correlation among multiple covariates together, and they may confound a relationship if they're considered together in the same model. And so controlling for multiple hypothesized confounders simultaneously kind of controls for the possibility of that joint confounding. And so again, that's another, this is kind of more of that theoretical approach to model building. That's really important. It's very important to know the literature. It's very important to know the subject area that you're doing the data for. All right, and then this other check-in exercise, I think that that many of you worked on this already, and we are about 5 minutes till 4 o'clock. So we will not go into breakout groups for this one. But basically, what we're looking at in this example, if I can pull it up here, what we are looking at in this example is we have MCO modeled, and then we have some other variables modeled as potential confounders. Right? And what we want to look at is we want to exponentiate these parameter estimates for MCO. And what we're trying to assess is, does age, race, ethnicity, and poverty, does accounting for these other variables, altogether as a group, do they seem to be changing the association between MCO and postpartum visits? And the answer is that they do change that sum. So we will not walk through that. You've probably gone through that in your group, because I didn't tell you not to, because I didn't think about it. But we'll not spend time doing that now. First, I want to ask, are there questions? there's been some good conversation in the chat. I've tried to keep up with it. Again, we'll talk more about model building on Friday, and I talked a little bit about it in the video for this session. Is this stuff useful? I've asked that a few times, but I want to make sure that it's kind of on target. All right, so I'm seeing folks saying that it is useful. Good. Great. Okay, so before we sign off today, one thing that I want to bring up, and as a faculty, we've talked about this a few times, is that we don't have a session built in on the topic of race and racism. But that's such an important topic for us to think about and talk about as maternal and child health epidemiologists, right? If, we have this data, and if we have the data, or if we're the keepers of the data, that we have some responsibility in this area, and we would be remiss if we did not talk about that in this training course. It can be a difficult conversation to have, but we have some opportunities to have those conversations through the data that we have available to our programs. And as epidemiologists, we have some ability to talk about these things in ways that others can't. So we will be bringing that up throughout the course in different sessions in order to try to get some of those conversations started. Ashley is going to be sending out or posting on the Google Classroom a couple of articles, one that was recently in Health Affairs about racism, and one that one of our experts, Pat Ocampo, co-authored 20 years ago about these issues in maternal and child health. I mean, she was, what, like 16 years old at the time or something?
I was a baby.
So
Yes,
yeah,
and
it's
I will
something that,
might chime in right now that those are uploaded in the Google Classroom. So they are under the folder Race and Racism Resources at the very end of the Google Classwork. So you can find those articles there. We just added another one. And feel free to start some conversation around that. If you would like some of your own resources added, let the faculty and I know, or Joe know, and we can certainly do that. But again, we want this to be an ongoing discussion throughout this training course.
yeah, and so we want to discuss these things that we have time, as we have time. There's a lot of expertise in this group around data, around social determinants of health, around race and racism and equity and justice and things like that. So let's use this time when we have all of these very smart people together, and so that we can learn from each other about some things that are very important and not just EpiMethod stuff. Sound good? All right. Thank you, everybody. It's 4 o'clock. Well, in my time, it's 4 o'clock. Everybody's in different time zones since we're not all together. But I really, really appreciate your attention and your thoughts today. Again, my sincere hope is that it's useful. I can't wait to talk to you again on Friday. And then, fortunately, you'll be mostly finished hearing from me. So, all right, I look forward to seeing everybody Friday, and have a great rest of your day. Thank you.
Bye-bye.